Good afternoon, everyone. So it gives me great pleasure to speak today at WFM. And I was asked earlier this morning if I might give an extra presentation because there's been a number of people who are sick. They're affected by Lufthansa's cancellation of many flights into our city. And so I actually thought that I would change this presentation and talk more about elastography techniques. And so tomorrow I will give the presentation that's got more clinical information on IBD. And so this presentation is entitled Ultrasound Elastography of the Bowel in Crohn's Disease, Imaging Principles, Technique, and Application. And the three people listed before my name include my wonderful student, who's a fellow right now in San Francisco, coming back to work with us next year, and my lead sonographer and my junior colleague. And so when we started to do this, I'm a clinician. I'm not a scientist and I'm not a physicist. And so I could never get up and give the presentations that Giovanna and Richard Barr do. And I quite frankly don't understand a lot of what they say to us. But we were very interested in the clinical relevance of doing elastography in the patient with IBD. And so I'll share with you today our trek that we took to a place where I feel that we now make a significant contribution to this patient population. And so my disclosure of interest is that we were supported by both Philips and Siemens when we were doing this work on elastography. And so what our objectives were was that the participant of this study, which was originally a poster at RSNA, is that they would understand the different elastography techniques, perform two-dimensional shear wave elastography of the bowel, and characterize bowel wall thickening and strictures, especially as representative of soft bowel due to active inflammation, or stiff bowel, which is thickening is related to chronic inflammatory muscular hypertrophy and less often to fibrosis, and utilize elastography to guide the choice of medical or surgical therapy. And so our target audience, of course, would be radiologists and gastroenterologists interested in Crohn's disease, and to the scientists and clinicians interested in quantitative biomarkers. And so what was our introduction to elastography? Well, we recognize that healthy and diseased tissues have different mechanical properties. And of course, I remember always as a student learning that palpation of a nodule was really the first evidence that we had that tissues change when they develop inflammatory or neoplastic change. And that's the basis of palpation in the clinical exam. And elastography provides us a non-invasive method to evaluate biologic tissue elasticity. And the technique has been developed over the years and combined with imaging. And of course, it brings with us all the advantages of ultrasound. It's safe, it's available, and it's relatively inexpensive. And so we based our interest originally on the principle that tissue stiffness altered by certain physiological and or pathological processes could be measured with elastography. So we started out looking at strain elastography, and this was an early technique, and it gives us qualitative assessment. And of course, I'm sure that you can all imagine, it's very difficult to even think of how we would go about doing a strain elastogram of the bowel, but it measures how tissue deforms to a mechanically applied force, and the subjectivity of the process limits its application and certainly limits it in the bowel. And so we, of course, first of all, tried this with point shear wave elastography when we actually had a visible region of interest or area to look at where we could place a box and then measure. And so this, of course, is related to ultrasound-induced acoustic RFE signals in a focal location. And they have shear wave creation, and then it's the shear wave propagation through the tissue that's measured quantitatively. And actually, for different reasons, but certainly partly because the physicists who originally were involved with my pursuit to do this, they told us that we're measuring the velocity of that wave, and so I've ever after pressure measured in meters per second, and we don't translate ours into kPa. And so, of course, the thing that became most attractive to us was when 2D shear wave elastography was available to us. And so this, of course, was so valuable because then we could have our area that we were looking at encompass the bowel, and the bowel being much smaller than the liver, this was something that was tremendously valuable to us. So this is ultrasound-induced RFE in multiple focal zones, and we would have real-time assessment over a larger area, and it generates both qualitative and quantitative information, and so that, of course, became our preferred choice when we were looking at the bowel. So the technique that we use to this day is the 2D shear wave elastography. So the elastography techniques are well documented for evaluation of the liver, but there's unique challenges when it comes to looking at the bowel. And we are familiar with really all of them. I'm sure every mistake you can make, we did. and so peristalsis is problematic, and so we can have the bowel quieted if we use pharmaceutical agents, but prefer not to. We're aware to this day that there's heterogeneity of the sample, and we'll show you what we do to take the optimal sample. And then depth of the lesions, they can both be too small, too deep, or they can be too superficial. And then, of course, how do we see the bowel well on ultrasound? We apply pressure. And as soon as we're applying pressure, then we're actually acting negatively in terms of getting a good elastography result. But so we standardize our technique to ensure as accurate as possible results and to have reproducible measurements over multiple exams. And we do very well at this, I believe. And so our total focus has been on 2D shear wave elastography. So the method includes a sample area selection, a dual display. So we always show both our elastogram and our quality measure. We select a region of interest, and then we do always look for the intraquartile range. And so here's just a loop of bowel that we're looking at that does not have significant thickening, but you can see that when we look at the bowel in long axis and in short axis, we place our sample area selection at the thickest point or the most suspicious point in long axis and in short axis. And it's our own preference. It wasn't because anybody made us or published that it was better, but we felt we could place our region of interest better by looking at the bowel in axial plane. So we sweep the bowel in long axis, we go to the short axis, and then we select our region of interest. And we put it within a box, and we make it as tight as possible to the margins of the bowel to get less error and a shorter wave propagation. And so here we're looking at a stiffness display. And so on the elastogram, the stiffness display is very similar across vendors. And it's best acquired if the patient has little or no respiratory motion. And we try to time it so that we have no problem with the peristalsis. And sometimes this is, of course, impossible. And so we have minimal probe pressure, and we try to look at the bowel between 2 and 5 centimeters from the surface of the transducer crystal. And so the optimal situation is when we have complete color fill-in of our sample area as here. And the stiffness as we use it is such that the blue represents a low shear wave speed or soft bowel, and that red represents a high shear wave speed or stiffening of the bowel. Now, in addition to that, we look at the quality display, and the quality indicator goes across the elastogram. And here, we get a different result than we did with the elastogram itself, in that the display type varies with the vendors. So all of the vendors are a bit different. And so here we have the quality display indicated by colored propagation waves. And we're looking for the place on the propagation waves where they're parallel and as straight as possible. So we would obviously select the right-hand side of this picture. So the stiffness and the quality displays together are used to select the most accurate region of interest, or ROI. And so here's a very nice example. So the quality display on the left-hand side is green, which means it's a good quality display. However, in the very center, we can see that there's a red area, which means it's poor data. And when we look at the actual stiffness display, we can see that there's signal loss on the blue stiffness scale on the stiffness side, both of them marked by the yellow arrow. Now, the region of interest selection, again, stiffness display and quality display. So the ROIs are always represented on our data as white circles, and they're selected using both displays to select the optimal place. And so we generally place 2 region of interest per elastogram, and the quality display here, we've placed it where we have the most straight and parallel lines, and this will create a quantitative stiffness measurement, and we measure that in meters per second. And we feel that the least error occurs in our measurements when we use the side wall on an axial view as compared to the front or the back wall. And so we take 10 samples and we measure this as meters per second. And of course, we have also the ability to express it as KPA. And then the interquartile range is the measure of the variability within our sample. And so we do know that using meters per second, if we were looking at the liver, that we would want it to be less than 0.15. And we do not know, and it's very hard for us to have good correlation with what we do. And so we think that that might be too stringent for the bowel, but that's only our impression as compared to actually documented by storing data. But so this is the schematic that my students made, and so we are very aware that if we're looking at virtually normal bowel, we get measurements that are less than about 1 meter per second. And so there we've said less than 1.2, and that's worked very well for us. If we get that measure, we just say the bowel is not increased in stiffness. And we know that the bowel that's been surgically removed and sometimes biopsied, that has measurements of greater than 2 meters per second, that those are that stiff, abnormally stiff bowel, and it has abnormal histology, either in the form of fibrosis, but more often in muscularization of the bowel wall. And of course, by the time they're up in the 3 and 4 meter range, those bowels, when they're taken out, they're like a pipe, basically. And so this is from our personal experience, and then we did publish from the University of Calgary our experience with a relatively small sample, but where we did have good correlation, and all of the bowel over 2 meters per second was abnormally muscularized, almost without exception. Now, the elastogram, we fit the sample area to the bowel. And so we use discretion at making it either smaller or larger. We try for no motion, as we've said, both from peristalsis and from respiration. And then we're very keenly aware that compression alters our results. So if we press very hard on the bowel, we get higher values. And so excess compression gives us an erroneous result. And so we adjust the size of the region of interest to fit the bowel wall as close as possible. And we avoid sampling the anterior bowel wall because we know that it's more susceptible to compressions. And so if we look at some of the pitfalls, the technical issues include especially excess pressure and a poor sample area selection for the elastogram and poor region of interest selection. And then patient-related, of course, respiration is a problem. So the closer we are to the diaphragm, the more difficult patient size, bowel peristalsis, and luminal content. And so here's a good example that they made intentionally to show how badly we can do. And so here on the grayscale image, the axial view is good, and you can see their box is close to the edge of the bowel. But when they've gone to do the elastography, you can see that the distance on the white arrows on both the stiffness and the quality display represents tissue that's outside of the bowel wall. So you can see, first of all, on the stiffness display that it's red at the front, and so they know that that's because they're pushing on the bowel. So when they push on the bowel, they can get that, and it's more exaggerated in the anterior portion of their sample area. And on the quality display, you can see, because it's looking at the bowel and the adjacent perienteric fat, that quality gram is really terrible. And here, pitfall related to poor ROI placement. And so you can see here that if we look at the ROI from the anterior and posterior walls, that they're very different. So the anterior wall, 2.5 meters per second, the posterior wall, only 1.5. So we're always trying to be as far back as we can. And then, of course, the bottom image shows an ROI that's too big in that it's encompassing both the thick bowel wall and the tissues around it. So we try to fit the ROI within the bowel wall. And then here, this is a better example if they had included a picture of the thin bowel, but you can see in the center on the axial view at the top and the long axis at the bottom that they're looking at very, very minimal bowel wall thickening. So this is a stricture, but it does not have bulk to it. And so, of course, here, again, they're encompassing far too much. And so thin bowel, in general terms, is not good, and hyperperistaltic bowel is not good. And so this study is one for sure where, although I ask my sonographers to do this on every case when we're looking at active IBD or suspicion of stricture, this is the place where, although they come back very often with exceptionally great results, they come back with poor results as well. And so what are the applications where we use this? Well, in general, we look at the stiffness of the bowel at the time of assessment, whether it's diagnosis, at acute presentation, flare, or surveillance. But it's also helpful if there's a choice for therapy. And then stricture characterization is really the major area where we look. And of course, we look, is the bowel soft, likely amenable to medical therapy, or does the patient have a stiff pipe-like stricture that would be better to be sent for surgery without having the patient take unnecessary medical therapy. And then for the assessment of therapeutic response assessment, I think this is a very exciting area. And of course, we compete here very strongly with MRI. And I think that our technique is more based in good science than MR, which is looking at interstitial contrast agent because of the difference in microbubble contrast and MR contrast. But so here's a patient who has a stricture. And so this very nice example, you can see the star on the top, on the middle images. That's showing us the pre-stenotic dilated segment of the bowel. And you can see very nicely the loop of bowel with the area where we plan to do our elastogram right at the area of narrowing. So at the point of transition of luminal size reduction is where we're going to go. And then we turn to the short axis because we get better images, and we try to place our region of interest in the side wall of that transition point. And so when we look at this patient, so he's a 55-year-old patient with Crohn's disease for 32 years. So he has the potential to have a chronic stricture. And so when we're looking at him, though, you can see the quality display is excellent and the stiffness display is excellent, and it's soft. And so this is an inflammatory stricture in spite of the length of time that he's had this, this disease. And so we recommend continuing medical management and possibly a change of his biologic. And here's another stricture shown the same way. You can see the pre-stenotic dilated bowel shown by the yellow stars. You can see that the bowel is hyperemic on color Doppler. And then when we look at our stiffness and quality display, you can see that the arrow's marking a very bright red area. So we know that's the stiffest point in that bowel. So that's where we perform our elastography. And when we look at this patient, we can see that we look just at the stiffness and quality display, that we have a good quality display. And when we place our regions of interest, we have a median velocity of 3.6 meters per second. This is a pipe. And so this patient requires surgical consult. And when this bowel was taken out, this is a purely chronic stricture with no significant inflammatory component. Just another example, again, active disease shown in the images in the bottom, and then that pre-stenotic dilated bowel shown on the top two images. And when we look at this patient, when we do the elastogram, we can see easily by our placement that this is soft bowel with only a velocity of 1.27 meters per second and a good IQR over median. So we do get some very good results. And so this patient was placed on steroids and comes back just after 9 days of intravenous steroid. You can see that his tight stricture and loop of bowel has let up considerably. So incomplete bowel obstruction has resolved. There's no pre-stenotic dilatation remaining, and the bowel remains thick and hyperemic. And when we actually do our measurements again, we can see that the peak enhancement has decreased from 26 decibels to 23, but the elastography remains soft, treatable bowel with medical therapy. So this is something that we like very much. So conclusions, we feel that bowel wall thickening is the hallmark of Crohn's disease, and our ambition is to characterize this as soft or stiff bowel using 2D shear wave elastography. And so qualitatively and quantitatively, we believe that increased propagation speed is very valuable for us and also for predicting therapeutic response. And these are just the references that we've used in our preparation of this material. And again, I'd like to acknowledge my student, Stephanie Wing, who's returning to work with me, much to my delight. Thank you.
Thank you, Stephanie. Now we